can just see everyone getting set up. Thank you for joining us this evening. It's really exciting to have you all here. I'll just give it a minute or so as we get settled, but just to kick things off, I would love to hear from everyone and get a bit of an idea of where you're joining us from. I did that in our last practitioner webinar, and it was actually quite nice to see the range of people that are joining us and from all over Australia. So in the chat, if you want to pop in where you're joining, that would be great. And what we'll do is I'll just do a bit of our intro as we get started. So welcome to our monthly Fireside chat. Today we'll be talking all about menopause and how this influences metabolic health. My name's Charlotte. I'm an accredited practicing dietitian here at Vively. Firstly, I'd like to begin our session by acknowledging the traditional owners on the land in which we meet today, wherever that is for you, and I pay my respects to elders past and present. Today, we're thrilled to be joined by Dr Louise Tulloh. So Louise is co-founder and medical director of Viv Health, an online medical service for women experiencing menopause. She's also a sports and exercise physician and past president of the Australasian College of Sport and Exercise Physicians. Louise's interest is in menopause care resulting from her personal experience combined with lacking expert medical care available for women in all stages of life. Midlife hormonal health is an extension of many years working with female athletes and women experiencing the aches and pains during perimenopause. Louise, we are absolutely thrilled to have you join us today.
Well, it's lovely to be here. I'm looking forward to it. As I was just saying, it's so apprehensive just as we approach these webinars. We think, how's it going to go? And it's always so much fun when we're actually doing it. So I'm looking forward to it.
Fantastic. Thank you for being here. And as always, we're joined by Dr. Michelle Woolhouse. Michelle is an integrative GP, keynote speaker, author, and of course, our founding medical director here at Vively. Now, if you feel comfortable, we'd love it if you could put your videos on. The reason we like this, it's really nice to connect with faces of the community that we're working with. At the end, we'll be having a Q&A session as well. So feel free, as questions pop up, to put them in the chat and I'll be able to direct those questions at the end of the session. But just some general housekeeping, if we could keep our microphones on mute for the duration of the session, it just helps so we don't get disrupted throughout those questions. And yes, we will be sending an email out afterwards. So we're recording this session. So for anyone that can't make it, you can catch up. Or if there's some juicy bits of information that you want to re-listen to, that'll be available later in the week. So now I'm going to pass over to Michelle.
Hi, everyone. Lovely to see you all again. Welcome, Louise. It's really exciting that you're here. It's obviously a really important topic, and I know it's front of mind for a lot of people. So thank you so much. I wanted to start with the basics. So if you can help us understand how the hormonal changes are experienced during the perimenopause/menopause transition and how that impacts a woman's metabolism.
Yeah, so I think it does help to ground ourselves in what's happening to your hormones. And the way we probably should start is what's happening during the average menstrual cycle. So if we just recap those high school science lessons around what's happening, we'll start there and we'll transition through to after our last period. So every month your ovary gets a few eggs ready to be released, and those eggs are surrounded as little follicles, and they all produce the hormone estrogen, a really important hormone for both men and women, but produce estrogen, and that makes the womb nice and fluffy, ready to have a pregnancy. So as one of those follicles gets chosen to be the selected one to release an egg, the hormone levels surge in the middle of the month and egg is released. Let's imagine we don't get pregnant this month. That little follicle then becomes what's called a corpus luteum. And I use these medical words because you'll often hear these phrases in luteal phase and other bits and pieces. So it becomes a little corpus luteum that produces the hormones estrogen and progesterone in the second half of the cycle. So in the first half, you've got estrogen. The second half, you've got estrogen and progesterone. And when the little cyst runs out of steam, you run out of hormones and you get a withdrawal bleed, and you do it all again month after month. So these sister hormones, estrogen, progesterone, made by our ovaries, are the ones that change during menopause, and they have this lovely dance month by month, which becomes disrupted as our ovaries start to mature and age. So the first thing that happens is the number of eggs that come from the vault of the ovary ready to possibly ovulate are reduced, and they become less in number. Therefore, we get less estrogen, less surge. Our periods start to get a bit shorter. Then what happens is we don't ovulate as much every month. And the consequence of that is we don't get that lovely progesterone surge in the second half of the menstrual cycle. And the consequences of that is the progesterone's not around to mop up all the fluffy stuff that estrogen causes. So fluffy is the estrogen is the fluffy, juicy hormone. It makes your skin fluffy, your vagina fluffy and juicy, and your uterine lining just fluffy and juicy. And so we get this unopposed estrogen progesterone effect when we're not ovulating. And what you'll see is heavy periods that often start to come a little bit late. And that's the characteristic of early perimenopause. At this point in time, as our hormones are changing, instead of this lovely dance they're doing, we're often got high estrogen, low progesterone. So they're becoming imbalanced. Some months they're normal, you can get pregnant. Some months you've got high estrogen, low progesterone. Some months you've got low estrogen, low progesterone. And so the perimenopause is characterized by this very imbalanced, unpredictable way of your hormones being. And so consequently, the symptoms that some to many women would experience during perimenopause reflect that. And the earliest ones would be headache changes, worsening PMS, mood changes, sleep disorders, that sort of thing. So as ovaries a few years more down the track, they start to stop ovulating altogether, and we will then have low but stable hormones, and we'll have our last period. 12 months after that, we're said to have gone through menopause, which is one day, and then after that, we're in postmenopause for the rest of our life. So now our hormones are not doing this thing, they're just doing this thing down low, and we get different symptoms. We might get more hot flushes, aches and pains, vaginal dryness, and so forth. And as we go on in time, many years after our last period, we have some health concerns that are more likely because we don't have those hormones. So that's bone health, heart health, brain health, and worsening vaginal dryness and bladder symptoms. So that's not really answering your question, Michelle, about the metabolic changes, but I think we need a framework of how this changes. And this might be 10 to 12 years, this stretch of time. Many women have no symptoms at all. 80% of women will have some symptoms during that transition period, and 20% have really bad symptoms. So if we come to the metabolic changes, it's really hard for researchers to unpick what is age-related and what's menopause and hormone-related because of that really long stretch of time that 10 years you're looking at someone. So it does appear that when women's hormones are low, estrogen and progesterone is low, we have less insulin sensitivity. So we have more insulin resistance and the metabolic consequences of insulin resistance. And we also have other cardiometabolic issues that become more prevalent after we go through menopause. And they would be our blood lipid profiles become more atherogenic. They would be we also have our inflammatory markers shift, and these are all thought to be hormone related. So basically insulin resistance increases. We see that with more shape shifting of our body, of where we store our body fat. Lipid profile becomes atherogenic and unhelpful towards a cardiac risk factor. And inflammatory markers would be the main metabolic consequences that we would see. And of course, the consequences of that are on heart disease, type 2 diabetes, and just, cardiometabolic health in general.
Wow. So many women experience weight gain. I mean, a lot of the research kind of says it's not necessarily pathognomonic, but a lot of women that I see definitely tend to kind of gain weight around the middle. Can you explain to us about why that is the case, even despite no change in diet, no change in exercise, or even increase in exercise? It doesn't seem to kind of have the same shift that what it did maybe in a couple of years before. Why is that? Why is that such an issue for women around that time?
I think it's an issue for women at any time, quite frankly. So I think that we have this general relationship with our weight and our body that is a little punishing. But if we look at that menopausal stage, research is actually quite conflicting as to whether menopause causes weight gain or if it's simply just that age-related metabolic changes, because premenopausal women steadily gain weight, postmenopausal women steadily gain weight, transitional women steadily gain weight, and men steadily gain weight. So it's quite where, whilst women say, but I gained weight, everyone's gaining weight on the trends are. Some research would suggest an average of 2.5 kilos of weight gain that might be hormonally dependent, but, you know, an average in research, you've got to remember that some women are 12 kilos, some women are taking off 2 kilos. So averages don't mean too much for the individual person. So I'm not sure whether we actually experience weight gain as a direct result of our metabolic changes of menopause, but I'm very convinced we have shape shifting. So the fat that we used to store generally in the healthy place around our bum and our thighs starts to shift around our trunk and our, you know, our bra and the back, our back fat, and our boobs get bigger and all that. So that we have to store more visceral abdominal fat, which is that kind of insulin resistance type fat deposition related to metabolic syndrome and worse health parameters. So I think there's shape shifting, and I'm convinced of that, and there's good research to support that, but I'm not so sure about the weight gain. The other thing is with women, just in case we don't get to talk about this, I really wish that women just would embrace their body or look at their body with a different lens at this point. You know, how long are we going to get irritated by the extra few kilos or trying to be a pre-baby weight or some 20-year-old weight? Like, how long are we going to worry about those sorts of things? And when are we going to start just enjoying our body being healthy and fit and full of energy? And I don't know, I think that I'd really like women to take a good hard look at what sort of ideals they're trying to achieve with this concern about weight gain. The other thing, Michelle, about, yes, they eat as much, they often eat less to try and manage this weight gain. And there is weight creep over time for everybody. So it is worthwhile paying attention to what you eat, your diet and your exercise. But I don't think it really works for midlife women to really flog themselves on the cardio sense. So obviously I've got my background in sport and exercise medicine. Midlife women, yes, we do need to do cardio, possibly more zone 2 cardio, which is not probably what we're doing when we're trying to lose weight. But we also need to make sure we don't sacrifice strength training at this point in our life. So excessive cardiovascular exercise, fitness exercise or aerobic exercise can be quite a stressor. And when your system is already feeling stressed from low sleep and all these sorts of things, it's not necessarily the right exercise for you, especially if you're trying to lose weight.
It's a great point, actually, in terms of, you know, the female form and body image. We know that body image it's a challenging time at that perimenopause, menopausal stage. But, you know, women are so used to their bodies changing, but it's societal pressure that stops us from accepting that natural ebb and flow of a woman's body, particularly if she does go on and have babies, or there's breastfeeding and there's puberty, and menopause is another kind of opportunity to embrace the cycles and the changes of life. I know I can see Charlotte sort of nodding as a dietitian and so aware of all of that body image issues for women. But I wanted to segue into stress, because you just mentioned, you know, high intensity exercise and that aerobic kind of capacity exercise. And a lot of people are really embracing that from a stress relieving agent. But in many ways, it's stressful, isn't it? If we over exercise, particularly if we've got other stresses going on. Talk to us about the role of stress and the metabolism, particularly during this time.
Well, Michelle, I reckon you could tell us more about this than I can.
He's my little baby, but I want your.
I can see that you want me to throw out my opinion, so throw in my opinion there. So I'm not midlife. Midlife is a time full of multiple stressors. Like, you're busy, you might have kids, you might be distressed you haven't had kids, you got parents, you got work, you've got all sorts of things going on. And then if you add menopausal lack of sleep and irritability to that, it's just a bit of a recipe for a difficult time. So a grumpy time. So there are external stresses and then internal stressors, aren't there? So we can only manage so many of the external stressors. Exercise is a fabulous way to, when we talk about stress, obviously we're talking about chronic, well, there is acute and then chronic stress. In chronic stress, we're talking about higher levels of circulating cortisol and stress hormones that all favor weight gain and insulin resistance. So they're not healthy hormones to be chronically stressed. Acute stressors lead to adaptation, so that's fine. So where the long distance exercise comes in is it becomes a chronic stressor if there's not enough recovery time. So it's about the amount of exercise. So when we're talking about blowing off some steam, improving our mood, a bit of huff and puff is fabulous, but you get the same benefit from 10, 15 minutes huff and puff as you do from an hour every day.
Yeah.
So you do not need high volumes of exercise for your mental health. You just need some short bursts of it. So, so the stress around exercise is a bit different to that. And I'm off the question. So I think you might want to get back onto the role of stress and weight gain and metabolism.
Well, we know, cortisol is related to insulin as well. And you mentioned, the increase of insulin sensitivity, the decrease of insulin sensitivity and increase of insulin resistance during that time. And I think when we've got a cortisol surge, it's almost like a double whammy. So it actually depletes insulin sensitivity as well. So at the same time, we've got kind of multiple different factors affecting the same thing. And you can see sometimes, I mean, I've had patients in my clinic that have actually put 6 kilos on in a week, because of a high level of stressor. So it's quite dramatic. I haven't seen it very often, but I've seen it numerous times over my career, which I'm sure you have too. Yeah. And it's amazing to see the impact, like the immediate impact of a chronic stressor turned acute over that particular time. So,
and there's an overlap, isn't there, with lack of sleep? So once you're stressed and anxious, you don't sleep, and then we know there's increased cortisol, reduced growth hormone, all sorts of knock-on effects in this sort of lifestyle package of wellness there that all impact negatively.
Absolutely. And I was going to bring you on to sleep because, I've been banging on about sleep. And in fact, I did a podcast earlier today and somebody said, you told me about sleep 15 years ago. So, I'm like a squeaky wheel really, but sleep is so important to kind of get that right. And at this particular stage of whether it's perimenopause or even menopause, often with the hot flushes, that constant waking, perhaps even anxiety, there's palpitations, etc. And even waking with joint aches, some people's aches and pains will impact sleep as well. What do you suggest for sleep management, and how do you support your women through getting better or optimizing their sleep during this time?
Well, so there's the menopause-related sleep issues, but then there's often chronic poor sleep habits and chronic insomnia, which if you bring that to perimenopause, then, it's not going to do well, is it? So, so just taking that long-term view and whether there's chronic insomnia and behavioural issues that need to be addressed. Women don't often approach us because they're looking for behavioural solutions for chronic insomnia, but I'm quite a believer in CBT for insomnia, which is probably the gold standard, reframing your thoughts and your relationship with sleep, not just the good sleep hygiene things, which we all kind of are familiar with. So that's the chronic sleep thing. We will often just talk about those basic sleep hygiene things, reiterate them, but many of the women that we see at Viv are really interested in whether hormone treatments will help them. And to be honest, hormone treatments work very well for sleep disorders when they're directly related to hormonal change. So interestingly enough, it's not just the hot flushes that wake people, or night sweats that wake people. So it's quite independent from the flushes. You can have disordered sleep. And the interesting thing, if any of the women out there are currently having flushes at nighttime, just pay attention. It seems to be that you wake up and then you have a hot flush. It's not that you wake up because of the hot flush, which is really interesting. We understand so very little about what's happening in the brain at these times. So hormone treatments can work quite well for sleep, particularly some of the body identical progesterones, which have the side effect of a bit of sleepiness. So they actually work quite quickly. And if you can, we also have many women who say, if you can just fix my sleep, I'll be happier. I can deal with the flushes. I just want my sleep fixed. So it's really important. And sometimes when it's hormonally related, we can put in all the lifestyle things, but sometimes we add in hormone treatments and that works quite well. Perfect.
So take us through HRT because, a lot has changed, obviously, and there was a massive issue back in the early 2000s, as you and I would know. But Lou, tell us about what happened. Tell us a little bit about the history of HRT and why it's still kind of, seemingly controversial, yet there's a lot of new research about in terms of newer ways to approach it.
Yeah, so I think the big bookmark around HRT story was really one single research paper, which is an incredible research paper from the Women's Health Initiative. And 2002. So this, just as a little backstory, because it's super interesting and unfortunately super disappointing, because much of our science and our recommendations are based on quite flawed interpretations of information that won't be isolated to this research group. It's pervasive. So the Women's Health Initiative was interested in whether HRT stopped people getting heart disease. And so they recruited, because it costs millions and millions and millions of dollars to create these studies where you're following people over time. They took women who were more likely to get heart disease. So they're older, they had risk factors, that many of them were, majority of them, I think, were more than 10 years after their last period. And they put them on these HRTs, which are what we call the old style. They were non-body identical HRTs that were commonly used at the time. And they followed them. And one of the side arms of the study was looking at breast cancer and some dementia and some other things. So they realized that fairly soon into the study, within about 5 years, I think, that there was an increased observation of breast cancer in one of the groups, in the groups that were given estrogen plus progesterone. When we talk about estrogen and progesterone, I'm not being technically correct here, because that should be the body identical ones, and there's all these little compounds that act like it. So I'm just going to use the terms generically. Estrogen and progesterone, they had an increased risk of breast cancer. So they paused the study, which was what they should have done, because that was an indicator to pause the study if they saw that, because it's unsafe. But before the researchers, the key researchers that actually even explored the meaning of this study, it was in the headlines. So somebody else within the study group had released that to the press, and it was all over the press. HRT causes breast cancer, blah, blah, blah. Doctors stopped prescribing it, women stopped taking it, and it's taken literally 20 years for that to recover. So when we look back on that data, what we see, and the follow-up data that's looked on that same group of people, what we see is the baseline risk of getting breast cancer is quite high, especially in the Western world, in the developed world. So it's 4 in 1,000 women every year will be diagnosed with breast cancer. It's quite common. So that's the base risk. The women who had estrogen and progesterone together, so essentially in this group, the group that had a uterus, they had an increased risk of 5 in 1,000. So that's an extra 1 in 1,000 people. And so that reads as 25%. What is it? 25% increased risk. 25% increased risk on a common condition sounds really bad. 1 in 1,000 diagnoses every year doesn't sound quite so bad. So this is where statistics are manipulated in order to get an impact. So that's the reality. What they didn't really highlight was the people on estrogen alone, so without the synthetic progesterone, actually had a reduction of 1 in 1,000 risk of breast cancer. So where we follow that over time and we look at other researchers, cross-sectional researchers, observational studies, etc., we're not seeing that repeated, and we're not seeing it with the body identical types of hormones that are currently used. But we will never, ever have another study so large that's what we call a randomized controlled trial, where half the people are given something and half another, and they're followed over time, because it costs too much money. So the information we have is really, there may be a small increased risk in breast cancer with the old style HRTs. We're not really seeing it, but there may be with the newer style body identical ones. And that risk is about the same as having 2 drinks of alcohol a day, being physically inactive, and being overweight. So it's like it's a lifestyle risk. And the main risk with breast cancer, and this is lost in the discussion, is being older and having had breast cancer before, and having a strong family history, not just someone in your family, but a strong family history. So, you know, a first-degree relative and another aunt or parent who were under 45 is actually a strong family history. It's not just somebody in your family, because it's a common condition. But the blowout is that really it was women feared breast cancer. They fear it much more than heart disease, which is a much more common killer of women than breast cancer. Even in that original paper, there was no increase in mortality or dying from breast cancer. There was just an increase in diagnosis. So I think what it comes down to is it's probably a small increased risk. You have your regular mammograms, know your own risk, decide what your risks are on the other side, because there are benefits of HRT with health and bones and heart disease and quality of life. So you've got to weigh those things up for you individually. So that's a long story, isn't it? It's a long story, the breast cancer story.
It is a long story, and it's really important to kind of discuss. And I'm absolutely with you. There is such a pervasive fear about cancer in general and breast cancer in particular. There's so much kind of in the media, you know, with regards to that. And you're absolutely right. Cardiovascular disease is such a significant such a significant disease in women, and certainly goes up postmenopausal to the same risk as men, whereas we're kind of protected when we're in our premenopausal years. Yeah. And I to tell us about, like, let's just stay on the story of HRT because it's really important. These days, you know, many of the more educated practitioners are actually using more bioidentical or bioidentical kind of hormones in their treatment profile. And really those old sort of style of HRT is really a little bit passé. Tell us about more of the common sort of ways that we treat HRT.
Yeah, so body identical just means that the compounds are the same chemical compound as your body makes naturally. So there's the estrogen and progesterone. The estrogen is usually can be given 3 ways. It can be given by a patch in Australia, by a patch, by a gel. Patch is put on twice a week. The gel's put on every day, or a tablet, a capsule. So the safest way to give the estrogen is through the skin, because there's absolutely no increased risk of blood clots, where there is a small increased risk when you take oral progesterone, because it kind of goes through the liver and affects the clotting factors there. It's still pretty low.
Oral estrogen, Luke.
Yeah, oral estrogen, so tablet. And so that's the estrogen. And if we talk about vaginal estrogen now, that comes as a pessary or a cream or a little tablet you pop into the vagina a couple of times a week to keep those tissues nice and plump. And even women who are on HRT often still need that for vaginal and bladder symptoms. And even women who cannot take HRT because they have breast cancer can usually still use vaginal estrogen for those symptoms. And I cannot emphasize how important it is that we don't neglect our vaginal health and sexual wellness as we get older. It's not a luxurious add-on. It's actually an important health factor. And so the progesterone in Australia can only by prescription, I should say these are all available prescription medications that I'm talking about, not compounded medications, which is slightly different. Progesterone comes as a capsule, micronized progesterone, which you take at night time. So they're the body identical ones. The older style ones are generally not used, but they are cheaper because they're on the PBS. And so this is a factor for many women, what they can actually afford to use. And so with safe monitoring, they're probably, quite safe. They're just not as safe.
That's so good. And I wanted to also just pick up on the wisdom that you gave us in your last explanation about weighing out risk versus benefits. So one of the things that I always talk about as well is there's so many things that do prevent long-term diseases, including cardiovascular disease and breast cancer. And and then we have one headline that kind of says you use one particular medication, it wipes out all of the other wisdom of the benefits of lifestyle change, which is what we're really, powerfully advocating at Vivally about lifestyle change. So, as we support our dietary intervention, our exercise, our stress, our sleep, and all of the other bonus things like, meditation and time in nature and even time restricted eating for some people, these almost like additional sort of benefits. What do you recommend for people from a lifestyle perspective, at Viv, and what do you find the most useful around this time?
So I think that menopause is a great opportunity to just take stock again and just put all the ducks in place, and to take to determine what the next 1/3 of your life is going to look like, just from a social point of view, from emotional point of view. What's important? What can you get rid of? Are there people that need to get rid of? Are there situations, jobs, whatever, stuff? What's important to you, and how you're going to look after yourself to make that, because there's less time ahead than there is behind now. So in terms of those lifestyle pillars, we're going to be on repeat here, Michelle. Sleep, managing ways to managing distress, because of course a little bit of stress is just normal and good. Healthy enough food without being paranoid about food. And that's where I love the continuous glucose monitoring, actually, because people get really paranoid about little bits of food, and then they can realize, oh, that didn't really make that much difference to I don't need to worry about, having that occasionally. Getting the right physical exercise. And for midlife women, I like heavy strength work or some strength work, and high impact for bones, and then also a bit of cardio. And if there's a weight or a metabolic issue, then I'm loving zone 2 cardio. And I think most people that's hard to do because it doesn't feel like you're really exercising. And I think that's a bit of it is the new wave, but there's great science behind zone 2 exercise, which maybe you want to speak to later. But so those are the lifestyle, and then connecting them more with social connection. Social connection is still really important, especially for women. Make sure that's in place, and then not doing too many toxic things, like not too much alcohol, not smoking, any other toxic things you do, trying to reduce or eliminate those. And then you've got your fine-tuning molecules around the edge, which are like your supplements or your herbal extracts, which should be personalized depending on your particular health issues, diet preferences, and so forth. And I consider hormone treatments as one of those molecules, and pharmaceuticals as one of those molecules. So I see it, that's how I see it. I'm pretty sure, what would you add to that?
Yeah, no, I'm totally with you, Lou, because I think what I often emphasize at menopause is it is a transition, and it's a very important, I think, spiritual and psychosocial transformational period for women. And I don't say it's the last opportunity for that, but it's certainly it's kind of the best opportunity, where women are at a time where they're kind of peaking in their physical form, in their fitness, in their wisdom, in their careers, in their life. And it's such a great time to take stock and really reflect back to the decades that have really informed this time. Most people are around kind of 50. The average age obviously is 51. So I had one lady who had regular periods up until 57, and it was like, I think her birth date was wrong. Her birth, she was quite incredible. But most people are around 50, 51, and there is a lot of emotional pressure and emotional load on women at that particular stage of their life, and certainly our current culture and current society, there's this unique stressor around women with aging parents, some with teen children, or even younger children at the time of menopause. And often, if they're working, they're really peaking in their careers, and then menopause hits. So it's almost like the first generation where we're having this multi kind of pronged challenge towards the menopause as well. So, I'm absolutely with you in terms of really making sure that there's a very broad and holistic approach to it too. But you mentioned supplements, and I know that they're specific, and I know that they're very unique. But there are some that are really quite evidence-based around this time. What are some of the most common, herbs, for example, that you prescribe around this time?
We don't prescribe a lot of herbs, only because almost everyone who makes an appointment of Viv has tried them already. So, and they're not working for them. So the research is soft, and possibly it's not robust research, but maybe black cohosh might be helpful. Red clover extracts might be helpful. So that would be the main two. And there's a raft of other hormonal extracts as well that are often combined in some of the more popular Instagram promoted hormone supplements for menopause. So they'd be the main ones. The supplements, so they're the herbals. The supplements that we often find are helpful for midlife are really vitamin D for some women is helpful, because we're really looking for bones. Some women who might be dairy intolerant, maybe needing calcium supplements. And then magnesium, we're often prescribing magnesium for its just general sedative, calming effects and muscular effects. So they would be the ones that we would do. But I am not an expert on herbal extracts, and the research is not strong for it. There's a high placebo effect for menopausal symptoms, and menopausal symptoms are subjective. That means that I can't see on an x-ray your broken bone. I can't see where the pain's coming from. So there's up to about 20-30% placebo effect in any subjective symptom at all, including menopause. So if you have mild symptoms, you may well get a positive benefit from using an over-the-counter herbal extract. And if that's working for you, that's perfect.
So one of the things, that's great. One of the things that Charlotte and I have been talking about, and we really wanted to see whether you had any thoughts around this, is that I had heard, and Charlotte had heard from at a particular conference that weight management or weight stabilizers after the menopause, almost a little bit like puberty where you lay down a little bit of extra body fat to help you go through a process. Is there any truth in that around the menopausal period of time, and does it change? So does weight management change after a significant period postmenopausal?
Could I answer that by just expanding that weight management concept around metabolic health and what's actually happening in a cellular level, because it might tie back to, I'm not aware of any weight stabilizing after menopause. We need to be careful in interpreting weight, that we're just not losing lean body mass and having fat tissue stable as well, because we don't actually want to lose any weight if it's lean mass. And that's the other thing to throw in here in case I forget, is that women and men, in fact, do better in the overweight category as we get older from health outcomes, rather than being normal or underweight. So we do not want to lose too much weight when we get older, because it leads to frailty and low muscle mass and sarcopenia. But it's so interesting. So just think of what happens. Your body adapts to low levels of hormones. So what you're really talking about is that there is a readjustment. There's a turbulent phase and a readjustment phase. So your body adapts to having its new low hormones. And we know that it does that because the symptoms don't last forever. So something changes. We also know some really cool stuff. So like, we know that if we give women who don't take hormones, if we give them estrogen, because estrogen works quite quickly. You're not waiting 3 months for estrogen to work. It's working within 24 hours. So, you can do really cool little studies on this. So if we give a group of early postmenopausal women, so within 5 years of their menopause, they're not taking any estrogen, we give them some estrogen and we monitor what happens in their cells. And then we take a group of late postmenopause after 10 years and we look at what's happening to them. We see some really interesting stuff. The first thing is that insulin sensitivity is increased in the early postmenopausal women given estrogen, but it's impaired when you give estrogen in the late menopausal women. So fascinating. The other thing we see muscles become stronger, lay down new muscle in response to resistance training and in response to injury coming back if given estrogen in the early postmenopausal phase. And there is no improvement when you do give estrogen in the late postmenopausal phase. We know that bone density starts to drop off in perimenopause and it continues for about 5 years and then it sort of plateaus, the rate of loss settles. So there is some biological adjustment to the low levels of hormones. And this is really important because there's a recent paper that was published, meta-analysis looking at the role of hormone therapy and dementia, because there was debatable, and that Women's Health Initiative suggested that hormone therapy increased your risk of dementia, but they had most of their women were very late, were in this bucket of late hormone takers, not early hormone takers. So when the meta-analysis took all the papers looking at all the studies looking into dementia and HRT, and they split them according to whether they had estrogen and progesterone, and or just estrogen, and whether they were early or late. Right. What they saw is the people who had estrogen alone had a 33% reduced risk of getting dementia if it was used early, and roughly a 20% increased risk if it was started late. So it flips because the metabolic impact of the hormone treatment varies. It's different.
So there's like a window of opportunity.
Yeah, it's called the timing and hypothesis, which is when we're doing this whole reboot and we're looking at, what we need to do for the rest of our life. We need to have the discussion about what hormone treatments, because they're safe, available, and generally affordable, safe for most women. What can they do for your health? You have got specific health risks, so you've got specific health concerns. So some people are scared to death of getting dementia. And again, it's out of balance. So you've got to keep it in balance. So that benefit in dementia is about the same as the lifestyle factors as well. So it's only an additional lifestyle factor kind of benefit. It's not stopping you it's about the same as being active. So let's not get that out of perspective. But yeah, that discussion around whether HRT is good for you is not just based on what symptoms you have and what your immediate quality of life, but also what health benefits you might serve to gain from that. Because if you are looking for the health benefits, particularly if you already know you've got low bone health, low bone density, there is a window of opportunity after which it doesn't help you. In fact, it may increase your risk. And we see the same with heart disease, Michelle. So it's the same flip with the heart disease risk.
Incredible. Wow,
Yeah, so interesting.
It's so interesting, and it's such good information. And so for anyone listening, like, it's really worth a discussion if you're in that perimenopause/menopausal phase with a doctor that's really up to date, like Lou, about this latest research on HRT. But we might shift it to questions now. Charlotte, I'm sure we've got tons. So we might need to take it online given timing. So let's open it up. What have you got for us?
I'm going to be a bit sneaky and ask my own question first. So I guess based on that timing factor, I feel like, and thank you for all of that information about like beginning with the life phases and that kind of thing. I'm wondering if you're not sure when you've started to enter perimenopause, for example, when should you go and see your doctor? Like, what sort of symptoms should you be noticing, or the severity, before you go and actually talk to your GP?
Oh, this is so hard, because early perimenopause, for some women, their mood disorders are really big, and recurrence of headaches that they might have had with periods before or whatever can be a real problem at a stage where our ability to treat that with hormone treatments is really limited. So because your hormones are high and up all over the place, for us to try and support that, the only way we can really treat it from a hormonal point of view is to obliterate your natural cycle with an oral contraceptive pill. So the solutions are not great. But if you are getting mood disorder, it's worth having a discussion with your GP. Could this be hormonal rather than, do I need an antidepressant? So often women will be given an SSRI or something like that. So all the lifestyle things can still help, and the oral contraceptive pill can happen really early. So the first thing you will notice is some mood changes, headache changes, and your period coming a little bit unusually. So the flow might change, it might become a little less, or it might be a bit more. It might happen a bit early. That would be the first changes that you would see. So you've really got to have some form of change in your period that from what it was before, to be able to say that you're even approaching any kind of hormonal transition. So they would be the early things. Early perimenopause is actually defined as when your period starts to become more than 7 days out of its usual length, your cycle. So then it becomes a little bit easier, because it's very clear that any kind of symptom in that symptom cluster, brain fog, aches and pains, fatigue, irritability, sleeplessness, all that sort of stuff, can be hormonal. And then the discussion around the health really has I think you've got a long time. I think really the health, to intervene with standard HRT type treatment, or in Australia we call it menopause hormone treatment, MHT, you really, when your periods are coming sort of a few months apart, that's an ideal time to start it if you want it for health and not symptoms. So the answer to your question is raise it early if you think your mood disorders are hormone related. May not be very easy to manage them then. Okay, just keeping in mind that sometimes you might be offered the pill and some women can't take the pill for various reasons. If your symptoms are heavy bleeding, that can be managed in various ways, like an IUD, or it can be managed with progesterone in part of the cycle to tidy up the womb lining in various ways. And then if your symptoms become more those classic flushes and stuff, then that's a little bit more straightforward. So what women will find is they will present with this early perimenopause. Women are becoming more aware of this because Mia Friedman's in perimenopause, so we're all suddenly aware that it's a thing. You'll often go to your GP, and it's going to be hard for your GP to treat you, because it is hard to treat at this stage, because it's chaotic. And really what you should be doing is looking for all those lifestyle things, making sure they're all lined up, observing your symptoms over time. But women are feeling frustrated because their GPs are probably just offering a prescription for an antidepressant. So it is really tricky. And it's hard for GPs. It is hard for GPs at this stage because there's not much on offer. So that's kind of probably not helping anyone there, Charlotte.
No, I think what you've highlighted is start to have those conversations, but equally start to notice within yourself, like, what am I feeling? Is this my normal? Given all of the other stresses at this period in your life as well, I think that sums it up quite nicely as well.
The other thing is that the hormonal symptoms initially will be cyclic. They will tend to be like a bad PMS. So they'll be in the week or two before the period comes. And that's another telling sign.
And the other thing to notice also is breast health too. So breast tenderness, breast swelling, those kind of things are quite distinctive. But the other thing that I would add as well is that naturopaths are pretty good at treating perimenopausal change as well. So away from the pure medical model of care, I know we've got a lot of naturopaths and nutritionists in our audiences, and they do very well in this particular stage of well-being. So,
and I think the other thing that they do really well is they keep with you.
Yeah.
They travel that journey with you, whereas this in and out of the medical system is not a very nurturing thing to do.
Yeah.
I think what you added as well, knowing that some of these symptoms are quite cyclical, especially with anxiety. That's one of the symptoms of perimenopause as well, isn't it? That there's an increased level of anxiety and brain fog or mental clarity. Is that right?
Yeah. And anxiety, it's kind of irritability is the hallmark feature of perimenopausal mood change, irritability and mood swings. That'd be the most common thing. And that brain fogginess, which you can all be reassured, it doesn't seem to be related to later dementia, or it doesn't seem to, we can't cognitively measure it. So if we do all these fancy cognitive tests, can't find any impairment. So we just assume that if we notice that we're forgetting a word or something, it's, oh my gosh, this thing's happening to me, whereas everyone else is doing that all the time and they're not worried about it. So sort of, don't worry about your brain. But yeah, menopause starts in the brain. And so there are lots of psychological and brain function symptoms.
We've also had quite a few people ask, what is usually the duration of HRT treatment?
So it depends on why you're taking it. So if you are taking it for symptoms, you might take it for about 5 years. If you take it around the time of your last period, would be very common, but there's no fixed time. So the old guidelines used to suggest you could take it for 5 years, at the lowest dose for 5 years, the shortest time of 5 years. So the current guidelines, almost all the guidelines around the world will actually say that you should take it as long as the risks outweigh the benefits. So if you're on it for health reasons, for example, bone health, you need to stop your HRT very carefully. So with consultation, monitoring your bone health. So if it's for health reasons, you may choose to continue it. And some women will just, I wish I knew who said this, but there's this delightful quote of some high profile woman was asked, when should you stop your HRT? She said, the day before you die. So there's no fixed time. As long as you're monitoring your health, you're monitoring your breast health and so forth. But the symptoms, when you do trial off it, the research suggests that it doesn't matter whether you just stop it cold turkey or you taper it down, you may still get your symptoms back. So if you get your symptoms back, you can choose to just resume it or see how you go with it or whatever. And we don't really understand. This tends to be much more so for estrogen therapy than progesterone therapy. So what's not often done, and what the naturopaths do really well, is use progesterone a lot more liberally at much higher dose. In sort of Western medicine, we use progesterone just to protect the endometrium, but it really has a lot of other benefits. It can be used as a therapeutic agent outside of the sort of hormonal cycling thing. So I would be thinking there are some really creative things with progesterone use alone when someone's stopping their estrogen, stopping their HRT, that could be utilized.
Yeah, I would concur with that. Progesterone's an excellent sleep agent, and it's also it's almost an antidote to cortisol. So that's a really beautiful thing, particularly for people that are stressed as well. So it's a good starting point, particularly in perimenopause, I find, when the cycles are going up and down, particularly with estrogen going up and down. I've found it quite useful to use that in those early stages.
Bit unfortunate that the prescription, to use compounded or prescription, because the prescription's quite expensive, and for the doses that we're talking about, we might be buying three boxes a month, so it's a bit of a commitment, isn't it?
It is, and cost, I mean, particularly the prometrium's way more expensive than the estrogel and the Sandrina. So estrogen cost is really low compared to the prometrium. It's extraordinarily high. So yeah, it is a factor for many women, and maybe we should start a protest.
Well, there is an inquiry.
Right.
There's a Senate inquiry, so we've got our submission ready, and that'll be certainly the availability of the safest hormone treatments.
Fantastic.
For women, yeah,
that's good to know.
I've had another question from a psychologist saying, I'm finding more women presenting with PMDD and referring off to co-treat. appropriately, reviewing hormones and not just antidepressants. Are you finding more PMDD presentations?
Michelle, I don't treat women who are cycling normally on the whole, but women who have had PMDD or postnatal depression are much more likely to have more mood disorders as they approach perimenopause, because they're usually progesterone sensitive. So, or hormone swing sensitive and progesterone sensitive. So I can't answer that question. I don't treat them, but Michelle,
I see a lot more PMDD. It was almost unheard of from a general practitioner point of view 20 odd years ago. A little bit like, ADHD, there's a lot more research, there's a lot more clarity around it. Probably in the past it was dismissed, but yes, certainly I've seen a rise over the last 5 or so years, for sure.
And do you use progesterone to help with that?
Yeah, I do. Lifestyle factors as well. So often they come to me quite fresh, and I find, the way that I would start is making sure that lifestyle medicine was very emphasized, diet, exercise, sleep, stress management, etc. And then progesterone during that luteal phase, so that second part of the cycle, tends to work well. I have seen a few people sensitive to that and actually having a negative impact. And yeah, so that's really the mainstay of treatment. There's a couple of herbs that I use to settle down the nervous system. And also I do quite a lot of neurological rewiring as well. And I think the other thing too is a lot of people are shamed around their emotional health hormonally and around the period cycle. So there's a lot of stigma from internally and externally around that too. So we talk a lot about that. We talk a lot about managing emotions and emotional regulation. And I've got a beautiful woman at the moment who I've been seeing for 12 months, and she had been on antidepressants for 14 years, since her teenage years, and she's finally just taken her last dose. So yeah, she's had an amazing recovery, very dedicated to herself, and so she's done very well.
Thank you for sharing that, Michelle. It's amazing to see, it's very complicated and every individual case is so different as well. And I think that's something that we need to remind ourselves as practitioners sometimes, that every person is going to display different symptoms, and their level of ability to, or what they're able to cope with, is different as well. And I think we as women particularly have this soldier on, you'll be right kind of approach as well. So having these conversations with and feeling heard with these symptoms, I think, is so important as well. We've had another question saying, I've had my uterus removed at 28 for a life-threatening situation. How can I advocate for myself with perimenopause, as I don't have a period to notice the changes? Louise, do you have any thoughts on that?
Yeah, so we can understand what's happening to your body roughly with your age. So as you approach 40, there will be some hormonal changes. We can do some fancy tests looking at because I presume you still got your ovaries. I hope you still have your ovaries. I'm going to assume that if you have got your ovaries left in there and that they're working fine. They don't always work fine after surgery, but let's assume that they are. So you'll still be cycling in the background and just not having that bleeding indicator. So if you're sensitive to your hormones, you will notice those cycling PMS, breast tenderness before the period is due, that sort of thing. You just won't get the bleeding. So you should notice that cyclic thing. Remember that many women don't even have any symptoms through perimenopause. So if you don't have symptoms through perimenopause, then that's great. But you will start to get these hormonal symptoms regardless of the bleeding, if you are subject to those hormonal symptoms. So noticing the symptoms, if that's happening to you, there are some tests we can do. As I mentioned, you can have a look at the follicle count, and we can have a look at a hormone called AMH, which give us an indication about how close you are towards menopause, what the functional age of your ovaries are. They don't give us any great predictive value, but they give us clues. And if most GPs will be very familiar with the fact that you don't need to have a uterus to have perimenopause, means what we would do if we wanted to treat that, and we were happy that you were in perimenopause, we might still use progesterone early on in perimenopause, depending on your symptoms, regardless of having the endometrium. You're not going to get really a standard GP to do that for you, because they think, they're taught that the progesterone is just for endometrial protection and you don't need it. That's a critical hormone, especially in perimenopause. So that would be the first step. And then if we wanted to layer up something else, we might add some estrogen in. And then we could know if you were in menopause itself by doing a blood test. We're not giving you hormones currently, doing a blood test, and we would notice a high brain hormone called FSH. And that usually indicates to us that you've had your last period, and that we can then go forth, if you wanted HRT, to use, estrogen continuously if need be. So advocating for yourself, reminding the doctor that you've still got ovaries and you're still cycling, monitoring your own symptoms and seeing if they're cyclic and how they're evolving over time. And then really we have to use our best clinical judgment as to what stage you're in and how to solve your hormonal symptoms over and up if we're using hormone therapies. And we're making assumptions here, and Michelle keeps bringing this back to remind everybody that these lifestyle foundations have to be in place. And then we layer on the supplements after that. So
fantastic. Thank you for that, Louise. Now, I am cautious of time, so I'm going to ask one question that I need you to answer quite briefly, which we haven't actually touched on. What would be the one piece of information that you would give to loved ones around someone struggling with menopause to help them understand what's happening?
Loved ones. I would encourage them to seek good care. I would share things and encourage them to seek good medical care, because I couldn't predict what would help. If my partner offered me a cup of tea when I was grumpy, and I would throw it in his face. Like, you see this advice, oh, be kind, give them a massage and all this stuff. And seriously, I don't want that. I want you to understand that I'm grumpy and it's not you. Might be you, but might not be you. And this is part of the thing. As women, we don't want to be told, oh, this is just your hormones. But on the other hand, we blame our hormones for things all the time. So it's like, we have to have a more intimate relationship with our hormones where we go with them. We understand that our moods will change and all those sorts of things. It's a normal flow and ebb of our monthly cycle, normal flow and ebb of our life. But it's a delicate thing with the partners. So I think more partners, male and female partners, are becoming aware of what perimenopause can do. So as we're becoming more aware, they're becoming more aware as well. They're talking about it amongst groups of men, for example. So I think that their awareness is better, and they're happy to be your partner in seeking help, whatever that is, rather than just telling you to fix it or making you a cup of tea.
Yes, that perfectly sums it up. Thank you. And of course, every situation is different, but I think having these conversations early where possible, but having the conversation is more important than not where possible. And obviously we're safe to do so as well. But I just want to thank you, Louise and Michelle. Thank you for all of that information and for diving so deep into menopause. I certainly have learned so much from today. And I'm sure there will be more questions. So I'm more than happy. We've got our Facebook community. If you want to continue the conversation, if you've got more questions and we haven't got to them tonight, please pop them in there as well, and we'll continue to learn more together. So thank you again. To find out more about Louise and her work, you can visit vivhealth.com.au, and we'll send that information in the follow-up email after this session as well. Our next Fireside Chat, actually, because of the end of the year, is going to be next Monday. So if you haven't got it in your calendars, we'll send out that information as well. So we will be exploring the festive season and some novel foods such as the impact of vinegar and honey on our metabolic health with Dr. Mark Cohen. So I'm really excited to dive into the festive season. I can't believe I'm saying that already. But thank you again, everyone. Thank you, Michelle. Thank you, Louise. And we'll talk again soon.
All right.
Thank you, everyone.
Bye.
Thanks.
Bye.